Dr. Sunita Verma, Dr. Virendra Gupta, sir, and the moderator will be Dr. R.K. Gupta, Dr. Jiten Nanduria, and Dr. Anshul Agarwal. He was here. कि मुसाफिर कल भी था, मुसाफिर आज भी हूँ, कल अपनों की तलाश में था, आज अपनी तलाश में हूँ. So the mic is yours, sir. Please kindly deliver your lecture. Thank you.
Can I start?
Yes, sir.
Sake. He is specifically recognized for his pioneer work in third space endoscopy in northern India, and he done his DM gastroenterology and hepatology from AIIMS, New Delhi. I welcome you, sir, and I hope everybody will find the session useful. Thank you.
Thanks a lot. Good evening to all of you. At the outset, thankful to Dr. Jan and Dr. Ram for the kind invitation and the opportunity. I must congratulate Dr. Ram Mudela for the first GASTROCON in BUNDELKHAND. So I will be discussing a very interesting topic of acute pancreatitis. I will start with a small trivia. So can anyone guess what is happening here? What is the diagnosis here? The patient has pain in the upper abdomen. He took the blood sample, and there is some milky appearance of the plasma. So very right. So it's a hyperlipidemia which led to pancreatitis. So what is pancreatitis? Pancreatitis is a acute pancreatitis, sudden inflammation in the pancreas, and it's a heterogeneous disease. Some patient they can have just mild pancreatitis, no organ failure, no local complication, and there should not be any mortality in the mild pancreatitis. On the other hand, many patients they can have a severe pancreatitis. They can develop respiratory failure, renal failure with a high chance of mortality. And the treatment need a team. There should be a team managing the patient. We need intensivist, we need physician, we need gastroenterologist, and we need good surgeon like Dr. Vivek Mangla sitting here, Dr. Sumitra Rawat. You need a good surgeon when you are managing acute pancreatitis. Then you need intervention radiologist who can put drain when required, and there is a role of dietitian also for managing the patient. So these are the key issues when we manage acute pancreatitis. We should know how to diagnose acute pancreatitis, what can be the different etiology, how can we prevent further attacks, how to assess severity, which patient require ICU admission, what is the role of IV fluids, antibiotic nutrition, how we manage the local complication, and when to do ERCP or lap cholecystectomy. And patient should be partner in the treatment. Nowadays, patient and family are aware. They want to know what we are managing, how we are managing. So patients are curious about the diagnosis, how we are diagnosing it, what's the known cause, how we define prognosis, treatment. So patient should be counseled regarding all these aspects when we are managing patient with the acute pancreatitis. That should not be ignored. So how we diagnose acute pancreatitis? There are 3 criteria. If out of 3 we have 2 criteria positive, we can diagnose acute pancreatitis. So there should be characteristic abdominal pain. So what is the characteristic pain of acute pancreatitis? So there should be pain in the epigastrium, which is going to the back, and there may be associated vomiting, and there may be relief in bending forward or lying in the prone position. That's a characteristic pain of the acute pancreatitis, and there should be high amylase or lipase more than 3 times the upper limit of normal. So if we have 2 criteria satisfied, we can diagnose acute pancreatitis. If the typical pain along with the risk factor, raised amylase lipase, we don't need any imaging and we can diagnose acute pancreatitis. If there is any doubt regarding diagnosis, then we can do imaging to confirm that there is a inflammation in the pancreas. On CT or ultrasound, we can see there is a bulky pancreas with inflammation, or there can be necrosis. So if you compare amylase and lipase is more sensitive and more specific than the amylase, and the lipase gets elevated for a longer time than the amylase. If the patient comes late in the course of disease, amylase may be normal. So if the patient comes at 4 days, so the amylase can be normal and the lipase will be high. So lipase is more sensitive and more specific than amylase. So these are the differential diagnosis of acute pancreatitis. So patient has epigastric pain. So it can be a gallstone disease, especially in the female patient. There can be epigastric pain. So it can be acute cholecystitis. There can be stone in the bile duct, can lead to similar pain. Sometimes patient with the intestinal obstruction, they will have pain, vomiting, abdomen distension. So that can be confused with the acute pancreatitis. In elderly patient, bowel ischemia, SMA, SMB thrombosis will have similar presentation. Patient will have pain, abdomen distension and vomiting. So that should also be kept in the mind. Perforation can have very similar presentation. We have seen patient managed as acute pancreatitis when with the CT scan they have perforation. This patient will have again pain, distension, and there will be increased amylase also. So this should be kept in mind. And MI can present as epigastric pain. It should be always remembered. One should always do a ECG, especially in the elderly patient, to rule out myocardial infarction. So these are the common causes of acute pancreatitis. Gallstone and alcohol are the most common causes of acute pancreatitis. And tobacco can also lead to acute pancreatitis. Should not be ignored. Always take a history of tobacco in these patients. Then after ERCP, many times there can be pancreatitis. During ERCP, we try to pass a guide wire into the bile duct, and we can see both the CBD and PD are aligned. Shivam will agree that many times when we try to pass wire into the bile duct, it can go into the pancreatic duct and it can lead to pancreatitis. Already discussed, increased triglyceride, increased calcium can lead to pancreatitis, and then there are viral infections like mumps, Coxsackie virus. During COVID, we have many cases of COVID pancreatitis with the high mortality. Hepatitis E virus can lead to acute pancreatitis. Many times after pancreatic surgery, patient can have, or after gallbladder surgery, patient can have acute pancreatitis. Drugs can lead to acute pancreatitis like thiazide, azathioprine, steroids can lead to acute pancreatitis. Now, we had a patient recently came to us with the valproate-induced severe pancreatitis. Many times on imaging we have pancreas division. Pancreas division as such doesn't lead to acute pancreatitis. Around 6% of population has acute pancreatitis, but that doesn't predispose to acute pancreatitis. And now we have weight loss medication like semaglutide, tirzepatide that can also lead to acute pancreatitis. And in elderly patient, pancreatic malignancy can lead to acute pancreatitis. If on imaging we have a dilated pancreatic duct, one should suspect either it can be a chronic pancreatitis or it can be a pancreatic malignancy. So, if on imaging we have duct like this, there are only 3 differential diagnoses. It can be a chronic pancreatitis, especially in the young patient. If in elderly patient we have a dilated duct, it can be an IPMN or it can be a ampullary carcinoma or pancreatic head carcinoma. Always take history of fever. Fever is very unusual in a patient with the acute pancreatitis. If patient gives history of fever followed by pain abdomen, it's likely viral pancreatitis. And one should take history of past episodes of repeated attacks of pancreatitis. In a young male who is non-alcoholic, not consuming alcohol, ultrasound normal, no gallstone, it's invariably is the early presentation of chronic pancreatitis. So recurrent acute pancreatitis, idiopathic in a young male, take it as an early presentation of chronic pancreatitis. Ultrasound should always be done in a patient with acute pancreatitis to rule out gallstone disease, especially in the middle-aged female, and always check for the calcium, parathermone and the triglyceride level in a patient with acute pancreatitis. Many times patient can have 2 etiology together, like gallstone with the hypercalcemia or gallstone with the increased triglyceride level. Day 1 LFT are mandatory in a patient with pancreatitis. Many times we have only amylase or lipase report. Any patient coming with the epigastric pain, please always do liver function test. If amylase and lipase are normal, but SGOT, ET, bilirubin is elevated, it's a CBD store. If along with the LFT derangement, especially ALT, if ALT is high, along with the raised amylase and lipase, it's a biliary pancreatitis. Even if the ultrasound is normal, gallbladder is normal, take it as a acute biliary pancreatitis, because microliths can be missed on the ultrasound. If you want to find out small stone in the gallbladder, we should do endoscopic ultrasound if trans-abdominal ultrasound is normal. So LFT is a mandatory test in a patient with the suspected acute pancreatitis. This is a classical report with a patient with the biliary pancreatitis, middle-aged female having deranged liver function test, raised amylase lipase. This patient will benefit from the lab cholecystectomy irrespective of the ultrasound finding. So what should be the next step? We should do the ultrasound or the endoscopic ultrasound. So this is how the gallstone lead to acute pancreatitis. We can see both the bile duct and the pancreatic duct open at the major papilla. They have a single opening. Both the bile duct and the pancreatic open together at the papilla. So sometimes stone from the gallbladder can pass into the bile duct and can lead to pancreatitis. And it can lead to pancreatic necrosis also. Stone is coming from the gallbladder going to the bile duct and blocking the duct, which will lead to inflammation of the duct and leading to swelling of pancreas, and sometimes there can be necrosis of pancreas leading to acute pancreatitis. Then What imaging we should do in a patient with the acute pancreatitis? These are 5 common tests: X-ray, ultrasound, CT scan, MRI, and the endoscopic ultrasound. So which test should be performed in a patient with acute pancreatitis? If a patient has abdominal distension, always rule out perforation. Patient coming to emergency, severe abdominal pain, abdominal distension, ILS, do an X-ray to rule out perforation. If there is a high suspicion of pancreatitis, one can do ultrasound to look for the pancreas and to look for the gallbladder, whether there is stone in the gallbladder or not. CT is not mandatory for diagnosis of pancreatitis. CT is done if there is a suspicion in the diagnosis of acute pancreatitis. Elderly patient, we have a suspicion of mesenteric ischemia. We can do a CT scan for a differential diagnosis of acute pancreatitis. Otherwise, the diagnosis is clear. We don't require CT to diagnose acute pancreatitis. Later in the course of pancreatitis, there can be multiple collections in the pancreas and we have to drain the collection. Then for the roadmap, we can do a CT scan. So X-ray, if there is a suspicion of perforation, ultrasound good enough to find the gallstone or confirm pancreatitis. CT when we are suspecting other differential diagnosis or complication of acute pancreatitis, or we want to assess the necrosis of the pancreas. So how we define the severity of pancreatitis? So there are 3 types of pancreatitis: mild pancreatitis, moderate pancreatitis, severe pancreatitis. Highly essential to classify into 3 categories for the prognostication. Patient having mild pancreatitis, only pain, no organ failure, there is hardly any mortality. Moderate pancreatitis, there will be local complication in the form of necrosis or collection. The mortality will be 5 to 10%. Third one is the most severe, when the patient has persistent organ failure like respiratory failure, renal failure, and this group has a mortality of 30 to 40%. So always essential to classify patient out of the 3 categories. And pancreatitis is an evolving disease. On the day 1, patient may look like stable patient, but over the next 2 to 3 days, it may convert into severe pancreatitis. So always look for the SIRS at day 1. What is SIRS? It's a systemic inflammatory response syndrome. Patient having tachycardia, hypothermia or hyperthermia, leukocytosis or leukopenia, and tachypnea or hypoxia. If out of 2 criteria are present, it indicates patient has SIRS, and in the future course patient can have a severe pancreatitis. So always check for the pulse rate, saturation, TLC count in these patients to predict the severity later in the course of the illness. So these are the patients who will require ICU care. Patient having organ failure, either respiratory or renal failure, should be managed in the ICU. Patient having infected necrosis along with the fever, leukocytosis, should be kept in ICU. Patient having intra-abdominal hemorrhage or the fistula with the colon, they should be managed in the ICU. And there are 2 phases of acute pancreatitis. The first 2 phases are the early phase. During early phase, there is a risk of organ failure, and the treatment is directed towards the organ failure. And organ stabilize by 2 weeks, and at that time we have local complication in the form of infected pancreatic necrosis. So first is the intravenous fluid. Most of the patients, they have hypovolemia, they have dehydration because of poor oral intake, because of pain they stop taking oral diet, they have vomiting, and there is a sequestration of fluid in the 3rd space. So there can be hypotension, there can be tachycardia. And so which fluid can be used? Ringer lactate and the normal saline has been most commonly used fluid, and studies have shown that ringer lactate can be better than normal saline in a patient with acute pancreatitis. It's an anti-inflammatory fluid. So how much fluid should we give for a patient with the acute pancreatitis? Earlier the concept was aggressive fluid for acute pancreatitis, that is around 3 to 4 liter fluid in the beginning, and after that high amount of fluid should be given, but that concept has changed after this landmark waterfall trial. So this trial randomized patient into 2 groups. One is the aggressive fluid, the bolus of 20 ml per kg followed by 3 ml per kg per hour fluid, and other group 1.5 ml kg per hour fluid to without any bolus. Bolus given only if there is a suspected dehydration, and bolus was 10 ml per kg. So when they compared aggressive with the moderate fluid, it was seen that patients who were given aggressive fluid, they had more fluid overload. They were developing the pulmonary edema. So aggressive fluid should be avoided in patients with the acute pancreatitis. It doesn't have any effect on the mortality, and it can increase the risk of pulmonary edema. So these are the recommendation for IV fluid. 1.5 ml per kg ringer lactate should be given to these patients, and bolus only if there is a hypovolemia. Target BP should be between 65 to 85 mean arterial pressure. Urine output should be 0.5 ml per kg per hour, and the one should be less than 20, hematocrit should be less than 44. This is how we titrate fluid in these patients. And this is again very important. Should we give antibiotics in a patient with acute pancreatitis? If it's a mild pancreatitis or moderate pancreatitis, these patients doesn't require antibiotics until unless they have biliary etiology along with the CBD stone and cholangitis. Otherwise, patient with a mild or moderate pancreatitis without cholangitis, they don't require heavy antibiotics. Many times we receive patients who have mild pancreatitis already on the meropenem. It can lead to multi-drug resistance bacteria or the fungal infection. So antibiotics should be avoided in a patient with the mild or moderate pancreatitis. In severe pancreatitis, in ICU patient, we can start prophylactic antibiotic. If patient has cholangitis, pneumonia or UTI, they can be started on antibiotic. For pain control, we can use either NSAIDs or we can use opioids for the control of pain in these patients. And the nutrition is again very essential. Early nutrition will prevent the bacterial endotoxemia, bacterial translocation across the small intestine. So when the pain reduces, we can start the oral feed. If patient is not able to take oral diet, we can place either nasojejunal or the nasogastric tube in these patients. But early feeding is mandatory in these patients, and enteral feeding is better than the parenteral nutrition. So this will definitely reduce the bacterial infection and reduce the mortality in these patients. So indication of ERCP are very clear. If the patient has cholangitis along with the pancreatitis, then we should do ERCP. So we should suspect cholangitis if there is a impacted stone at ampulla, high bilirubin and fever in these patients. With the ERCP, we can remove the stone from the bile duct. We can see here it's a stone impacted at the papilla, leading to both pancreatitis and cholangitis. Once the stone was removed, there was gush of pus which could be seen. So ERCP should be done only if there is a cholangitis, so we can see flow of pus in this patient. And various drugs have been used to prevent severe pancreatitis like gabapentin, but there is no proven role of medication to prevent the severity of pancreatitis. Unitastatin has been also used, but there is no role of pharmacotherapy for prevention of severity of pancreatitis. So there is only a supportive care which should be offered to these patients. So as we discussed, in second week onward, there is a local complication. Patient will have fever and there can be collections inside the abdomen. This red marks indicate the most common site of collection in a patient with acute pancreatitis. So pancreas is present from this side to this, epigastrium and the left hypochondrium. So mostly when we do CT scan, the collection will be either in the epigastric area or the left paracolic area. The collection in the epigastrium can be drained by the endoscopic ulcum guided drainage, and the paracolic collection can be drained by the IR guided approach. So whenever we are draining collection, one should do a CT scan. Any black area in the CT scan can be suspected to have pancreatic necrosis. MRI is better than CT scan to define the collection. Here it looks like it's a old fluid, but on MRI, whitish area is the fluid and the black area is the solid. It's essential to classify the solid content because more solid content indicate the failure of either endotherapy or the percutaneous drainage. These collections can be drained by the endoscopic EUS guided drainage from the stomach. We can puncture this collection and we can place a stent and we can drain the collection inside the stomach. Lap cholecystectomy. So if the patient has biliary pancreatitis, when should we offer lap cholecystectomy in this patient? If it's a mild acute pancreatitis, before discharge, this patient should be offered lap cholecystectomy. Otherwise, there is a high chance of recurrence of acute cholecystitis. In moderate or severe pancreatitis, we should wait for stabilization of the patient. All the collections should have been treated, and after that, we can go for the lap cholecystectomy. Many times, patient had a pseudocyst along with the gallbladder stone, so we can offer surgery for both. We can do the laparoscopic drainage of the cyst, and we can remove gallbladder in the same setting. But in mild acute pancreatitis, before discharge, patient should be offered surgery. To summarize, gallbladder stone and the alcohol are the most common cause of acute pancreatitis, and diagnosis can be made by the clinical presentation, raised amylase, lipase, or imaging. Day 1 LFT are the very important investigation along with the amylase lipase in a patient with suspected acute pancreatitis. Fluid has an important role. Ringer lactate is better than normal saline. Aggressive fluid can be harmful. So there will be moderate fluid resuscitation in these patients. No role of prophylactic antibiotic until unless patient has a severe pancreatitis or has a cholangitis along with the pancreatitis. There is no drug at the moment which can prevent the severity of acute pancreatitis. Treatment is mainly supportive care for the patients. Earlier, the patient was treated with the open surgery that has given way for the either endoscopic drainage or the minimal invasive surgery for these patients. So, endoscopic approach can be followed with for the infected pancreatic necrosis, or the IR guided approach can be followed for the left paraconic collection, and the epigastric collections can be drained with the endoscopic epigastric collection can be drained with the endoscopic drainage. And in patient with mild pancreatitis, the gallbladder surgery should be done prior to discharge. Thank you very much for your patience.
Thanks, sir, for sharing your valuable knowledge. Any questions, please?
Excellent talk, Dr. Vivek Bungla. This is excellent talk. Acute pancreatitis and even in the management of the chronic pancreatitis.
So that's a very good question. Excessive bowel sound, they have steatorrhea. So steatorrhea is pale bulky stool. So we should do the fecal elastase level. If fecal elastase is less than 100, we can diagnose pancreatic exocrine insufficiency, and they should be given the pancreatic enzyme supplementation. And the dose is lipase equivalent of 40,000 units with each meal and 20,000 with the snacks. So that is the chronic pancreatitis. Acute pancreatitis, there is no well-defined role of pancreatic enzyme supplementation. So sometime during hospital stay, we can, if there is a significant necrosis of the pancreas, CD showing very 80 to 90% of necrosis in these patients, we can add pancreatic supplementation during the hospital stay. And similarly, after the discharge, if the patient has excessive bowel sound, frothy stool, in those patients we can add the pancreatic enzyme supplementation. So there is definite role in the chronic pancreatitis. Acute pancreatitis, still the role has to be defined. You can go by the symptom, and if there is suspicion, please check for the fecal elastase. Less than 100, you can start the enzymes. So once you have started for the chronic pancreatitis, it will be lifelong for the patient because it's an irreversible damage in patient with the chronic pancreatitis. So once the function is lost, it will never recover.
Thank you.
Many preparations are coming in the market for this enzyme in the chronic pancreatitis.
So, yeah, it's again very good question. In India, we have multiple preparations, and all of them are equal actually. And the budget dose is 40,000 units with each meal. Yes, all the preparations are equal. Whatever we have in India, all are equal.
There is one more question. We are using so much of antiseptic. So what is your experience regarding this drug with pancreatitis?
So in the last 1 year, we had at least 4 patients admitted with us due to acute pancreatitis after usage of GLP-1 analogs. So either it can lead to direct toxicity of the pancreas, and sometimes due to rapid weight loss, there can be stone formation in the gallbladder that can lead to biliary pancreatitis. So once the pancreatitis, they have pancreatitis, it should be avoided.
Incidents are coming.
Yeah. So we are seeing a lot of patients now.
So analgesic,
Opioid agents has been used for the acute pancreatitis. So if the patient has the renal failure, one should definitely avoid NSAIDs, and if there is ileus, then one should avoid the opioids.
Then what is the answer?
No, you can use tramadol, pentajocin, you can use it.
Pentagocin we can use.
Yeah, they are studied with the pentajocin, it gives a good relief.
Even tramadol also.
Tramadol you can use.
Thank you so much. Now I request Dr. Someone please come on the stage.
Look at here. Look at here.
Dr. Dr. Jiten Chirokia. To Dr. Anshul Agarwal. And to Dr. Abhay Gupta. Thank you so much. Now coming up with our
सर यहाँ ओके यहाँ देखिएगा ओके 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 लुक इट हियर थैंक यू सर